who will provide information on the addenda, and then we have a scheduled speaker at 2 o'clock on some of the proposals, and then we have another scheduled listener presenter at 2:30. So with that, I will turn this over to Beth.
I will not be adjusting the podium. I hope you can see me. We're on page 60 of the document, which is the tabular addenda. And all of the addenda items we're presenting here in the next several pages are proposed to be effective October 1, 2014. So while sometimes people view, oh, it's just addenda items, sometimes it can make a big difference depending on what we're doing. So we welcome your comments, not only on whether you agree with or disagree with any of these items, but whether you feel they should be implemented right away or whether they should wait. Some of these come to us from users who've been testing the classification, and they find typographical errors or inconsistencies that we're fixing, and other things actually have come from the WHO because they still do update ICD-10, so we have to incorporate changes that they've approved. They have a time frame as well, so a lot of these changes are going into place in ICD-10 January 2014, so we have to have them in our addenda for 10/1/2014, so I'll try to point those out as well. So on page 60, so this is the tabular, under A41, this is a chapter level, or a category level excludes one note for sepsis, excluding A41.9, which seemed to conflict, excluding a code out of your own category, so we're going to remove that excludes, no, we're proposing to remove it, I should say. I'm instructing everybody to say we're proposing, and I already said we're going to do this. The next item under B17.9 does come from the WHO, and that's to add acute infectious hepatitis NOS to B17.9. I think previously it was at B15.9 under hepatitis A, so they're proposing to put it under acute viral hepatitis. Under category D76, there are several excludes notes that we're modifying. This is again based on a WHO change where they were separating out reticuloendotheliosis from reticulosis. So we're modifying according to what they've implemented at the ICD-10 level. And this will have some changes in the index as well, as we'll see when we get there. Under E13, which is other specified diabetes, just going to add an excludes note for type 1 diabetes. Again, this was actually WHO adding that. I had that barley soup for lunch, and I think the cumin's choking me, but it was delicious. At E88.42, Murph syndrome, it was recommended to us to add the word progressive to the code also note for myoclonic epilepsy. This came from a requester that it had to do with, I think, the type of epilepsy that's associated with the Murph syndrome. We have also run some of these neurologic-related changes past the American Academy of Neurology, and they'll either be commenting here or commenting in writing. Dr. Powers couldn't be at the meeting this time. At FO2, we're proposing to delete under excludes 1 the dementia with Parkinsonism and move it up to the code first list. There's a big long list of conditions there associated with dementia in other diseases classified elsewhere, and so this is one of them. I think we made a change a few years ago to Parkinsonism, and we probably should have moved this out of there to the code first list, so proposing to do that. Under I50.9, this is changing an excludes 1 to an excludes 2. For this condition, as Sue pointed out, sometimes these are a little too exclusive, so it was felt that sometimes you may have a need to code fluid overload with heart failure when they're unrelated to each other. Under I-69, and anytime if I'm going along, if I go too fast, stop me and make a comment, but I'll watch the microphone from time to time. At I-69-123, we had a cutting and pasting error that we, under the inclusion terms, stuttering following non-traumatic, whatever type of intracerebral hemorrhage or stroke it was, we forgot to change the word. I think they all say subarachnoid at the fifth and sixth character 23, so we've got several codes that we need to change to the appropriate word to match the type of intracerebral incident that occurred. And at I-97.82, post-procedural cerebral and vascular infarct, we are going to proposing to revise the titles of 8.820 and 821 to post-procedural cerebral vascular infarction following a cardiac surgery. Right now it says during cardiac surgery, so it seemed to conflict to say post-procedural during a surgery. So at K5281, again proposing to change an excludes 1 to an excludes 2 because the condition being excluded, if you go to K20.0, there's an excludes 2 there for this condition, so we feel they should match. At M90, under osteopathies and diseases classified elsewhere, we do have an excludes 1 there for osteochondritis, osteomyelitis, and osteopathy in diabetes mellitus, and I think right now it says 0.61, which is arthropathy, and it was pointed out to us that it should be 0.69, which is other, I think other manifestations at the E codes. So we just want to make that correction. At O13, gestational pregnancy-induced hypertension without significant proteinuria, WHO has added an includes term for transient hypertension of pregnancy to send it to this category. At O24, both the O24.0 and the O24.1, a revision of a lot of code titles. WHO actually just switched over to using type 1 diabetes and type 2 diabetes instead of insulin-dependent and non-insulin-dependent. And in changing some titles, they also kind of changed the order of the words. So we were trying to match, even though we had type 1 in our titles, we were trying to match their phrasing. So we're revising the code titles to reflect that. On page 62, at O34.0, it was pointed out to us that bicornate uterus and the inclusion terms that you see here, maternal care for double uterus and maternal care for uterus bicornis, right now ICD-10-CM, for some reason we had them going to O34.59, and it didn't seem correct. Someone pointed this out to us, and so we actually did run this by our experts at ACOG, and they concur that it really should go to O34.0. So this would be a reindexing as well as including these terms under O34.0. And O99.6, adding an excludes 2 note for hemorrhoids in pregnancy. This actually was added by WHO. WHO doesn't do excludes 1 and 2, but they did add this as an excludes note. So we made it an excludes 2. At O99.82, is Linda in the room? Linda Holtzman? Oh, there she is. Okay, we're up to Streptococcus Be Carrier. She had several suggestions about maybe better representing Streptococcus Be Carrier state, whether in pregnancy or not, by just adding some excludes note to direct people to appropriate codes. Whether you're pregnant, you'd be at the O99.82, but if you're not, you'd be at the Z22.330. So we're making some changes in the tabular. You see here at O99.8, and when you get to the index, we've proposing to revise some and add some index entries to better direct people in coding that condition. At the section for R40 to R46, which is symptoms and signs involving cognition, perception, emotional state, and behavior, it was recommended to us to change an excludes 1 to an excludes 2 for symptoms and signs constituting part of a pattern of mental disorder, which excludes all of Chapter 5. This person felt it was too exclusive, that maybe there was some conditions in this section that they may want to use with a Chapter 5 code. I'm assuming if they are not a part of a mental disorder. So the proposal is to change that from an excludes 1 to an excludes 2. Of course, we always have our guidelines that say you don't code signs or symptoms that are part of a established diagnosis that would come into play. So would invite any comments on changing that from a 1 to a 2. And similarly, at section R70 to R79, abnormal findings on examination of blood without diagnosis, changing this list of excludes from 1 to 2. This was seemed a little more restrictive, that sometimes you can have a symptom in this section and it isn't related to the conditions that were being excluded. And so there was a need to be able to use, one of these codes in the R70 to 79 along with a diagnosis from this list in another chapter when they weren't related. So it was proposed to change that from excludes 1 to excludes 2, and we would modify the titles so they'd be full titles in that list. So that's why you see the revisions and the deletions to better reflect the titles for those excludes list. Okay, and then at W89, exposure to man-made visible and ultraviolet light. Actually, with one rare occasion where we were going to change an excludes 2 to an excludes 1 for exposure to sunlight, meaning you either are exposed to man-made light or exposed to sunlight on a given condition. So we were proposing to revise that to an excludes 1. And then at X32, exposure to sunlight, there's an excludes 1 note, X32, exposure to sunlight, there's an excludes 1 note for radiation-related disorders of skin and subcutaneous tissue, L55 to 59, that when we looked at it more closely, it just didn't seem like there was really a need for this exclusion note, so we were proposing to delete it. Page 63, at X39, we were fixing there's a typographical error in the code, and that excludes 1 note, so we're proposing to fix it to be the correct code, Z77.123. And at Z22.330, this was again another excludes note that we're proposing to add to better represent the carrier of Streptococcus B, that if you're pregnant, you should be back at the 099.82. And I have a commenter, Pat.
Yes, Pat Brooks from CMS. I see you say at the top of the section that these are proposed addenda for October 1st, 2014, but I also see included in the addendum are some code title changes, specifically on page 61, the
Right.
197.024. We would urge you strongly not to make code title changes because we've heard from many payers, providers. These title changes take extensive system updates, changes when you revise the title, delete the title, or add the title. These are equally big impacts. So if these are good ideas, I would suggest anything that involves the code title itself be deferred to October 1st, 2015.
Okay, we'll take that. Thank you. We'll take that into consideration. Again, those in particular, but I take your comments are well taken. Those are kind of phrasing changes, but I see your point that any code title change kind of, the red flag goes up. You've got mail. Okay, Nellie.
Nellie from the AHA. As a follow-up to Pat's comment, I'm a little bit conflicted because our position has been that we would not want any kind of changes, new codes, revision of titles, October 1st, 2014, for the same reasons that Pat mentioned, but also what I mentioned earlier. But I realize also that there are problems that would be helpful to have addressed before, as in, excludes 1 nodes that are too restrictive, and people might have created edits that now, would preclude someone from assigning the 2 codes when it really should have been an excludes 2. So my question, and I don't even know if you can answer this today, but maybe something you consider. Is there the possibility, because this would, I think, would help me sort of present it to my members that I would need to consult, is there possibility of sort of splitting out addenda changes where They don't include new codes. They don't include revision of titles. And in addition, making it, just this 1 year, making it available at the very, very beginning of 2014. In other words, releasing the, whatever version we're going to use at the beginning of 2014 as opposed to like the spring, summer, like when you usually publish the addenda and the new version. Because I think that if we do it early enough, there might still be the possibility of, having 9 months, 10 months to make those changes, get people trained, correct whatever has been put out. But if the answer is no, we can't, then people might feel differently about having any kind of addenda changes.
Mm-hmm. Yeah, you're right, I can't answer that today. But it would be really helpful to, if in your comments, you could be specific on what things would sort of feel like okay to do at that early stage versus absolutely don't try to do this at all. Because, as you know, getting things ready early when comment periods end in mid-November, and then we have to all discuss it all and stuff. So, but it'd be really good to have specifically what concerns your members the most in terms of. I don't know if Rhonda's still in the room, but she used the phrase, "What sends you from 0 to 1?"
Sue from AHIMA, and I completely agree with Nellie, and I'm somewhat conflicted on this issue myself and have to give it a little bit more thought, I think, before I submit my written comments, because on the one hand, we obviously don't want people being forced to code wrong, at the start of ICD-10 or be coding in one direction, then a year later it goes in a totally different direction. But on the other hand, a lot of these seemingly minor changes, like the ones Pat mentioned, and even changing excludes notes and that kind of thing, have major ramifications throughout systems changes and edits and other things that people are in the process of doing now. Mm-hmm. And we've heard that to go back and redo your ICD-10 implementation work in the last 6 months before implementation is just an astronomically expensive and not even completely feasible endeavor, resulting in the potential that they're missed, and now you've got some people have it in their systems and some people don't have these changes in and miss them, and I think we really have to think about the value of making these changes next year, and I feel a little bit more differently about this late date in the process than I did earlier in the code freeze, when I wanted all the errors and everything corrected. But now that we're talking about the same exact date as the go live for ICD-10, I think that we really need to think through some of these revisions and whether it would be better to hold them for 2015.
Okay, thank you. Okay. All right, with that then we'll move on to page 64, which is the index changes in the same, again, proposed effective date, and your comments well taken about 10/1/2014. We'll just review what's being proposed here. So under the main term adenoma, the changes here for the indexing of microcystic pancreas and unspecified site come from WHO. I think it's changing it from D13.7 to 6. The next change, burn hip, changing to thigh. This is, to me, an attempt to get you right where you need to go, because I think right now it says go to lower limb, and then you get there and you go to the hip and it says go to the thigh. It's like, just take me to the thigh. So get to the net of it. Anyway, the next item under carrier, this is part of the, again, indexing of group B, streptococcal bacterial disease, whether in pregnancy or not, putting some additions there to direct coders better for whether you're a carrier. And you'll see we have those also further down under delivery, and I think under postpartum and pregnancy, we have similar changes to that effect. The next item, this would come under the term an error that right now under coma, hyperglycemic, for example, I think it says C diabetes coma, and there's no such entry in the index, so we want to better direct you to say diabetes by type, hyperosmolarity with coma, because that's the way you have to get to that code. So we're just trying to direct you better. Under convulsions, there are a couple of terms, benign neonatal and neonatal benign, which both say C. epilepsy, generalized idiopathic. It was recommended to us to remove those because we removed the terms, I think, from the, I want to say the G40.3. And so we did ask AAN about this, whether was the intent just to remove the inclusion terms and only have them indexed, or should we remove them from the index as well? We're actually waiting for comment on them, but we thought we'd go ahead and propose them. Cyst, cervical lateral, the correction of the code there, the revision of the code comes from WHO to send it to Q18.0. Dehydration with hypernatremia and hyponatremia, it was recommended we add these two because ICD-9 has it indexed that way. Right now you only have hypertonic and hypotonic there, so it was felt that it would be helpful to have hypernatremia and hyponatremia indexed as well. And then again, the delivery C-section for Streptococcus group B and complicated by Streptococcus group B, just revising those notes. Actually, to better reflect the title of what it is. It was pointed out to us that just saying, I think it just said Streptococcus B. It was, I think David was pointing out to us that that wasn't quite correct. Okay, then under diabetes, diabetic, with osteomyelitis, it was recommended to us to add this to the index because right now the only way you really find out how to code that is when you go to code osteomyelitis, you have the excludes note that sends you to diabetes. So we were proposing to add osteomyelitis under each of the types of diabetes to the appropriate code within that category for the type of diabetes. Brittle diabetes right now isn't indexed, and although when we were looking into it, it was some people were feeling it was an outdated term. Other people felt it may still be used, that we should still index it. And ICD-10 has it indexed to diabetes type 1, so that's where we were proposing to add it. And in doing so, we discovered a couple of terms that are included at type 1 diabetes that are not indexed, and that's diabetes due to autoimmune process and immune-mediated pancreatic islet beta cell destruction. So we were proposing to add those as well as idiopathic diabetes to say code to diabetes type 1. Under distress, it was recommended to us to better reflect what's at these codes. At J80, I think the code title is Acute Respiratory Distress Syndrome. And so it was recommended to us to correct the index that for acute respiratory distress, that be indexed to R06.00, which I think is dyspnea, and that the syndrome be the only thing indexed to J80. And this may be where Sue and Nellie are talking about, you know, you're sending it to one code now and you want to send it to a different code. That could cause somebody, I guess, to have to change several policies and things like that. So it's kind of important to know whether that we should do this before 10/1/2014 or wait till 10/1/2015. Similarly, we would revise distress respiratory and include adult child as non-essential modifiers to R0600 rather than have them indexed to J80. Under effect, anesthesia, we're correcting an entry that is at the wrong level. Code 029.3 is actually for an adverse effect of a local anesthesia in pregnancy, so we need to correct that level so that it's appropriately placed in the indexed. Under epilepsy myoclonus, this is similar to the tabular change to revise the term progressive, remove it from being a non-essential modifier, and create a separate index entry to send that to C. epilepsy generalized idiopathic. Under hepatitis, this is related to the WHO change where they're removing acute infectious to B17.9. We'd make that, proposing that revision as well as removing with hepatic coma because there is no code for that at B17.9. So we would remove that under both entries that we're revising. Salivary gland injury, and actually the next three items, the revisions well, actually, no. The injury to the gland salivaries to correct an inconsistency. Under one entry, we have SO9.99 or something like that, and then SO9.93, so we're trying to correct it to be consistent to SO9.93. But the next two entries for melanocytoma of the eyeball and necrosis of the cornea, those are revisions that were proposed and approved by WHO. Osteomyelitis, similar to what I mentioned earlier, adding this to the index so you can find it in the index as well as in the tabular. Pregnancy and puerperal infection, Streptococcus group B, we would make modifications there to clarify it's Streptococcus group B or GBS. Resistance, organisms resistant to drugs, revising the entry for drug to have Z16.30 because we don't have a default right now. It was recommended that we have a default for just drug-resistant organism. And then correcting the spelling of antimycobacterial and adding a couple of entries under multiple drugs that aren't there already. Reticuloendotheliosis and reticulosis entries, those changes came to us from WHO to revise or remove and put them under one or the other. And sequestration, this is a change that came from WHO. We didn't know they knew about sequestration, but it's a different type of sequestration, which is disc sequestration. They proposed to add the phrase C displacement intervertebral disc. And then under virus, swine influenza, that's correcting a misspelling of the word influenza in the index. And then in the table of drugs, those two revisions are to fix typographical spelling errors, which is the reason I didn't list all the codes out to the right. That was just to let you know where they are in the table of drugs. I think the letter L is actually a number 1, so we need to correct that. Are there any comments at all on either of these parts of the addenda over and above what we've heard? If not, I guess I'll turn that over to David, I think is going to do the next topic. Thank you.
All right. Our next topic will be gastrointestinal stromal tumor, going back to the beginning here on page 11. And we will also have someone on the phone to answer some clinical questions, Dr. Brian Rubin. Charlie, do we have Dr. Rubin on the phone now? Can he hear us? And can
yes,
we
this is Brian Rubin. I can hear you.
All right, and we can hear you too. Great.
Terrific.
All right. I'm going to talk briefly about things in overview, and then I'll let you say some more about things and take clinical questions first, if that works for everybody. Does that sound good to you?
Yeah, sounds fine.
All right. And let me say, Dr. Brian Rubin, MD, PhD, is the Director of Soft Tissue Pathology at the Cleveland Clinic Lerner Research Center and Taussig Cancer Center. And Dr. Rubin, would you like to say anything else to introduce yourself?
Well, I've been working on gastrointestinal stromal tumors for most of my career, and so that means I've been working on them for about 15 years, and I'm considered an expert in the area of diagnostics and treatment of GIST.
Uh-huh. All right. I'll briefly introduce them, and then I'll let you talk in more detail. So, first, gastrointestinal stromal tumors, or GISTs, are the most common soft tissue sarcoma of mesenchymal origin. They're a kind of tumor of the gastrointestinal tract thought to originate from certain specialized cells, interstitial cells of Cajal. GISTs are most commonly found in adults between ages 40 to 70. Historically, they were thought to be either malignant or benign, but now most experts apparently think that they are generally malignant. There's between about 4,000 to 5,000 new cases of these every year in the U.S. Most common locations are the stomach and the small intestine, although they can occur anywhere in the GI tract and certain other times in the abdomen, such as omentum or peritoneum. And we've gotten a proposal to create specific codes for GIST from Novartis. The current beta version of ICD-11, I will also note, does already include specific codes for gastrointestinal stromal tumors. So we also have that background. And there's a number of ways in which GIST is different from other types of cancers, particularly related to the types of treatments that work for it. And let me turn it over to Dr. Brian Rubin to talk about that a little bit.
So, I mean, GISTs are a paradigm for treating solid tumors with targeted therapies. We discovered about 15 years ago that they're driven by specific mutations in certain tyrosine kinases that are amenable to treatment. So they're a paradigm for oncogene addiction. So these cancers are always addicted to either KIT or PDGFR-A, or now we know a small percentage are addicted to other things. And when we verify that they contain certain mutations, they tend to respond to drugs that target those mutationally activated proteins. So again, they're an important paradigm for treatment of solid cancers that are driven by oncogenes and that are essentially oncogene addicted. And we've learned a lot about how to treat them over the last 15 years. We've gone through several levels of resistance, and now we have a stratification of 3 FDA-approved drugs that we can use. They're not all made by the same drug company. In fact, each one's made by a different drug company. And we took a disease which was uniformly lethal 15 years ago. The median survival was 6 months, to patients essentially being chronically treated who will drop off and die over time due to various forms of resistance. But the impact has been huge on the whole field of GIST treatment.
Okay. So going from something that's essentially untreatable to being very treatable is certainly a wonderful thing. And I don't recall. Would you care to tell us more about the specific drugs that the FDA has approved for GIST?
So first-line therapy is imatinib mesylate, which is known commercially as Gleevec. That's a Novartis drug, and that targets the most common types of mutant KIT. When patients escape imatinib, which happens with a median of about 2 years, there are some patients who've been stable on Gleevec now for 13 years, but it's a small number of patients. We think that 90% plus will become resistant at various times, starting at about 2 years. We then switch them over to sunitinib, which is a Pfizer drug, and sunitinib, which is also known as Sutent, stabilizes patients again. Not quite as long, but we know at the molecular level that what the most common mutations that are resistance mutations to Gleevec are susceptible to sunitinib, and that's why sunitinib works well in the second line. And then our third drug that was just FDA approved is regorafenib. It's a Bayer drug. And again, looking at the molecular level, the things that escape Sutent are susceptible to regorafenib, and so regorafenib stabilizes patients. But even though regorafenib is a relatively recently used drug, we already have resistance, and we know we're going to end up moving on to the fourth line therapy, and there are many candidates. But those are the 3 FDA-approved drugs. Okay.
And yeah, I recall there were various other tyrosine kinase inhibitors that are out there, some FDA approved for various other indications, which I presume might have some potential to work based on other factors, I imagine. So
that's right, and the field is moving more towards cocktail-based therapies. So there's a lot of preclinical data, in fact, in our lab and other labs, where we're looking at combinations of inhibitors. And so you can take a first-line inhibitor like a KIT inhibitor, either imatinib, sorafenib, regorafenib, Sutent, and combine that with something like a MEK inhibitor, like Mekinist, which is FDA approved for the treatment of melanoma. And it does decrease the time or increases the time to resistance greatly, at least in a dish and in the mouse models. And so we have some trials that are starting now looking at combinations of like MEK inhibitors or MAP kinase inhibitors with a KIT inhibitor or PI3K inhibitors in combination with KIT inhibitors.
Okay, and let's see. Let me mention also, back up a little. As I recall, the very first line treatment for anyone with GIST would be surgical treatment. Take the cancer out, presumably, as much as possible. But many times, of course, you can't get all of it, and or it may recur. And then the other major issues were that essentially regular chemotherapy and regular radiation therapy have essentially no beneficial effect. That, as I understand it,
that's correct. So
that's pretty much a summary of it. Yeah.
Disease essentially was untreatable. We also do give Gleevec. It is FDA approved in the adjuvant setting. And so we have data out to 3 years now showing that 3 years of Gleevec given to high-risk GIST patients decreases the incidence of metastasis in patients who've had a total resection. But the most experience using Gleevec has been in the metastatic setting where patients tend to metastasize. They tend to present with livers that are full of cancer or diffusely throughout the abdomen. And those patients actually respond quite well. We can stabilize 85% of them.
Okay, so even with metastasis found, it still is very effective. So that's certainly something I think very good to hear for treatment purposes.
Yeah, I mean, and the motivation for making an ICD code for GIST is so that we can, since the treatment is so specific, and it's really only for this disease. You can take something like leiomyosarcoma of the gut, which looks very similar under the microscope, but has a totally different molecular profile. And they won't respond at all to any of the drugs we've just discussed. The motivation for having an ICD code that can be followed and monitored is that the patients are getting the right therapies who need it. So just patients getting Gleevec or another KIT inhibitor, whereas diseases like leiomyosarcoma would get something totally different. And since we have such a great therapy, we really want to get it into the right people, and this will allow, we believe that the ICD coding will allow us to follow not only at a research level, but also from many different levels to make sure that these drugs are administered to the correct patients. They're actually quite expensive as well, and so you don't want to give them to, for instance, insurance companies would be motivated not to give them to patients who don't need them, and that makes sense, whereas if they really need the drug, it's going to work miracles, and then we want to make sure that they really get it. So that was a lot of the motivation.
Okay, and again, from the standpoint of coding purposes, this has already been added to ICD-11.
Yep.
And that was, I think, based on expert input into the creation process for ICD-11. So it's good to see that that has already happened. So, all right. Do we have any clinical questions for Dr. Rubin right now? We'll invite you to ask questions if desired here. And Dr. Rubin, let me go ahead and go through some of the codes that we're recommending to add and other things also, and talk about them briefly, if we can do that.
Sure.
So first, tabular modifications. We have the section malignant neoplasms of digestive organs, C15 to C26. Sometime at this point in time, it's possible some people would code a GIST there now, since it is a type of gastrointestinal system tumor. So our proposal here is to add an excludes note there for gastrointestinal stromal tumors to a new subcategory, which will be C49.A. And then we will, at category C49, which is malignant neoplasm of other connective and soft tissue, we would add a new subcategory, C49.A, gastrointestinal stromal tumor, and we would add a number of new codes at this new subcategory, and I'll just go through them briefly here. The first would be a new code C49.A0 for gastrointestinal stromal tumor unspecified site. The next would be C49.A1 for gist of esophagus. .A2, stomach. .A3, small intestine. .A4, large intestine. .A5, rectum. And .A9 for other sites. And for any types of questions on where some of these might go, we also have some index modifications. We would have tumor, stromal, gastrointestinal, malignant. This would be going initially to C49.A0, which is the unspecified. And then colon would be to the C49A4, the large intestine. And we would have a number of things going to the small intestine, the C49A3. These would include duodenum, ileum, jejunum, and meckel diverticulum. And then we would also have omentum and peritoneum, both indexed to C49.A9, the other sites. And that pretty much covers both the tabular and index modifications we'd be proposing. Dr. Rubin, any thoughts on these?
No, I mean, it looks perfect to me. In the index, I think that you didn't mention rectum, but I think that should be C49.A5, as you sort of mentioned above. No, we're really happy with this. I think it's really going to make a huge improvement in our ability to monitor these diseases. So I think this looks perfect.
Yeah,
and I know the other experts, we've circulated this around, also agreed.
That's good to hear. And on rectum, that was part of the code title there, and the code titles would all be indexed in addition. So I was, with the index modifications, I was only reading things that would be in addition to things that were in the code titles.
Oh, got it. Yeah,
So,
I understood. Thank you.
Okay.
Got that.
Okay. And you've, I think you've covered all the things related to this in good detail, and we've got a good picture of what's going on. Let me look for questions now, and Linda.
Yes, this is Linda from Clarity Coding. Do I understand correctly then that in ICD-10 we'll want to classify GIST always to malignant tumor? Or it would always be considered malignant? So if you see a diagnosis that just says GIST, you're going to code it as malignant?
Yes.
Okay.
Yeah, I mean, the data that's out there shows that essentially all of these have malignant potential. We do risk stratify them, and according to criteria that have been developed over a number of centers into different risk categories, but we do consider that every GIST has some risk of malignant potential. And so I think coding them all as malignant is appropriate.
Okay. Then my comment is a technical one on the index. Right now, under tumor, stromal, gastrointestinal, it gives you the option in the index for malignant, benign, and uncertain for all of these anatomic sites. So you'd have to go through and strike every one of those for benign and uncertain and just classify them all to malignant in the index to make sure that the index is consistent with the tabular and how we want to classify this. Also, I think it would be helpful to actually have the term GIST in the index, because you have to know to go, tumor, stromal, gastro, but usually what you see in the chart is GIST. So if you had that somewhere in the index, that would be helpful. It
is a well-accepted acronym, so I think that's a great suggestion.
Okay. So, and your point is well taken, Linda, on the benign and the uncertain. I'll have to look back at exactly what entries we've got, but we're proposing just to add these below the malignant entry. And yes, I'll have to look back on those. But yeah, benign and uncertain, we should probably just strike those and leave the presumption that this will always be malignant.
Then my only other comment would be, I think you need some kind of an excludes note, and I'm not sure if it should be a 1 or a 2 at this point, but some kind of an excludes note at C49.4, because that might be where people would tend to go. So just a reminder at C49.4 not to include GIST there and send it over to C49A. Thanks.
Okay, that's something we can look at too.
Great suggestions.
And yes, if we do an entry for GIST, I think we'll probably just say C, tumor, stromal, gastrointestinal, but we'll go from there. Yeah.
Nellie Leon, Chisane, American Hospital Association. Just a question. By your showing us the index modifications, are you saying that this is in addition to adding them to the neoplasm table, or are you suggesting that it would only be in the index and not the neoplasm table? Because I think they need to be on the table.
Well, I think we could put it in the neoplasm table also, but yes, this would be in addition.
Okay, thank you.
Yeah. But we may not do entries for benign and uncertain in the table. We may just leave it as malignant, and since the presumption is that it is supposed to be malignant, that's what it's understood to be now, as I understand. So, yep. Okay.
And so ICD-11 will be out in 2015. Is that correct?
I'm
sorry.
That's an interesting question. I guess I could just say this is probably not the forum to address that, although I will say that one person here who probably knows more about it than others shook her head and said, no, don't think so. But on the other hand, ICD-11 will be used for mortality coding purposes, and it might be used in some clinical settings in some countries where they might use it. ICD-10 is used directly in the UK, for example. We would not expect we would be using ICD-11 directly for clinical purposes in the United States, although certainly and the level of detail ICD-11 will have will be quite different than ICD-10-CM in some areas. There will be, for the most part, probably less clinical detail in many areas, and there would be a lot less ability to update it. For example, when we're supposed to update on a regular basis, as Congress has told us, we have to be ready and able to do that. So ICD-11 would not be feasible for us to put that in the hands of WHO to try to update. Just as a very quick aside on that, and we don't need to probably dwell on that further. Any other questions here, either clinical or coding related on GIST? All right, I'm seeing no further questions at this point in time. Dr. Rubin, you've been very helpful in going through the clinical details on this and answering these questions for us, and I appreciate you taking the time to do that.
Well, thank you very much for what you guys are doing.
All right. And I will, I'm going to have to turn to Donna and figure out how soon we will want to put someone else on. Dr. Rubin, I think we'll let you go and say goodbye, and we'll be going on shortly here.
Thanks very much. Have a good day.
Thank you. You too. And I believe that our next topic will be on oral and maxillofacial fractures, and I believe that that Shannon will be telling us about that. And I further believe that we're going to have to get someone else on the phone shortly too, so they'll be working on that.
Okay, if you turn in your packet to page 27, the next topic that we're going to be covering, as David stated, is oral and maxillofacial fractures. And we're just waiting to connect Dr. James Mercer. So let me just make sure that we have Dr. James Mercer on the line. Dr. Mercer?
Yes, I am. Just came on.
Okay, great. Dr. Mercer is with the American Association of Oral and Maxillofacial Surgeons. Dr. Mercer, I'm going to go ahead and present the coding consideration for the first of 3 topics, and then I'll open the floor up for any clinical questions and/or comments, okay? So currently, there is no way to specifically report laterality of oral and maxillofacial fractures, whereas there are options for reporting fractures of other bilateral bones, joints, and ligaments. AAOMS has requested adding codes to ICD-10-CM to specifically report laterality of oral and maxillofacial fractures. So we are proposing to add new codes at section S0210, titled Unspecified Fracture of Base of Skull, to capture right side, left side, and unspecified side. A similar change would take place, be proposed to take place at section S02.3, again capturing the laterality. We're also proposing at section S02.11 to revise some existing codes to capture unspecified side. And you'll also note that we are proposing to add some alpha letters, and this is because we were unable to add the additional characters at the 6-character level because those were already taken. So as a result, we are proposing to add that 6th character being an alpha letter. And I also want to point out just a typo on the reading here is S02.118. It reads other fracture, or it should be of occiput, unspecified side, and we will plan to fix that typo. We are also proposing at S02.4, title being fracture of malar, maxillary, and zygoma bones, to revise several codes that are already existing to capture that unspecified side, and again adding the alpha letters because the 6th character was already, the 7th character was already taken, so for the 6th character we are proposing to add the alpha letters. Under section S02.6, fracture of mandible, we are proposing to revise code S02.600, again to capture that unspecified side. And in addition to that, we would like to propose adding new codes for the laterality at that section, as well as section S02.61, section S02.62, S02.63, S02.64, S02.65. Under section S02.8, again, fracture, there's title, fracture of other specified skull and facial bones. We are proposing to add the right side, left side, and unspecified laterality codes to that section as well. Are there any questions from the floor, clinical and/or just comments? Seeing none, I'm going to go to the next topic, which is found on page 30. The topic is mandibular joint disorders. The American Society of Oral and Maxillofacial Surgeons are proposing to add codes to specifically report, again, laterality of the temporomandibular joint disorders. Currently, there is no way to code laterality of the temporomandibular joints, which is a bilateral joint. So we are proposing to add new codes at section M26.60, mandibular joint disorder unspecified, to capture the right, left, bilateral, and unspecified sides. Similar changes are proposed to Section M 26.61, M 26.62, and M 26.63. Are there any clinical questions and/or comments on this topic? Okay, we will go to the last of the oral maxillofacial proposals, that being on page 31. The topic is dislocation and sprain of joints and ligaments, jaw. Again, this is being brought to us from AAOMS, proposing to add new codes for laterality. Currently, there is no way to specifically report the dislocation of the right or left temporomandibular joint, whereas there are options for reporting the dislocation in other bilateral joints and ligaments. As the prior proposal, we are proposing on this topic to add new codes under section S03.0 for laterality, and similar changes to take place at S03.4, sprain of the jaw. Any clinical questions and/or comments? Hearing none. Dr. Mercer, was there anything else that you wanted to add? I didn't have any questions here in the audience.
Nope, you presented it well. I appreciate the consideration. It really just adds a granularity and corrects some inconsistencies. So appreciate the consideration.
Thank you for your time as well. Have
Sure.
a good. Okay, have a good day.
Thanks.
Okay, I'm turning the podium back over to Ms. Donna.
Okay, so that concludes presentation of proposals for today. Again, we do have 10 proposals that will be presented tomorrow. We will be starting at 9 o'clock. Did want to have a little housekeeping note in case you weren't able to take notes as quickly as you would like here in the audience, and for those on the phone. The webcast will be posted on the CMS website at a later date. We don't know what that date is yet, but that will be posted, so you would have something to refer back to if your note-taking skills weren't keeping up with some of the discussions. And again, we would like you to very much consider, as part of your comments, the written comments, whether or not you agree, disagree, or have alternative options for the proposals presented, but also to comment on the timing for some of those proposals, since some of them are being requested for October 1, 2014. And with that, you get to have an early release. And we thank you for your participation. We look forward to seeing all of you again tomorrow. Have a great rest of the day.